As a reminder, today listener viewer requested topic of working with our patients who have cognitive decline disorders like dementia, Alzheimer's. How do we work with them? How do we treat them? And especially if we're doing local anesthesia. My thoughts on that. And I am actually really excited to talk about this subject. And one, because it is a viewer requested topic, so I know it's something that you want. And I love that because I really want to share information that works for you guys. And two, it is something that I hadn't really spent a lot of time really thinking about and diving into. So it gave me an opportunity to go down that road as well and look at some items. So thank you to Kyla, I believe is who it was that had asked for that. So as we get started, I'll wait for more people to come in, but I will say that this last weekend I got to go to Vermont to speak to the Vermont Dental Hygiene Association, and that was wonderful. We talked about local anesthesia, some techniques. It was a very beautiful group. Vermont is a gorgeous area. The only drawback is I left my computer charging cable at the hotel in the conference room. So working on getting that back. But yeah, don't do that. All right, so let's dive into this topic of providing care for our patients with dementia, especially if we're doing local anesthesia procedures. And one of the things, and I just so that you guys know, like I have notes that I take on these items when I go and look this stuff up and research it, is one of the things that I think is really important for us to remember is to have a true understanding of our patient's cognitive level. Right? I think that there are times when maybe family members or friends may suspect that their loved one has a cognitive issue, whether it's Alzheimer's or dementia, and for the sake of simplicity and the sake of today's session, I'll probably go back and forth between saying dementia and Alzheimer's. But when I say that, I truly mean the whole avenue of anybody that has a cognitive decline. So when you hear dementia, Alzheimer's, just kind of anybody with a cognitive decline, this is where I want us to be thinking. But I think it's important for us to have a true understanding of where our patient lands on that spectrum. Like, has it been officially diagnosed, or is this what their friends and families are thinking? Is this something that you're suspecting? So we need to find out if it's been diagnosed. And then the other thing is, once it's been diagnosed and we have that in their patient's health history, we need to have an understanding of if there is a individual to provide medical consent for them. So usually there's some sort of forms, documents. We need to make sure we have that information just from a legal standpoint. Do they have the capacity to consent and have informed consent? Okay, so it is important to understand that, and if they have a family member or a caregiver that does that for them. So that's one of the things. The other thing is, if they do have a caregiver that is with them and assisting them with their daily hygiene activities, getting an idea of what that is like as well. So just having that conversation. And I know we know this, we do this on a regular basis, but it's one of those things. It's just good to have that information and that update. When it comes time to doing treatment, my best advice is to have a conversation with the caregiver, whoever is with them the most, if you can, to find out if there are any triggering items, if there are motions or words or activities that might be triggering. It's always good to know if there's anything like that so you can avoid saying or doing those items, okay? The other thing is looking to see what treatment needs to be done. When it's time to treatment plan and do your procedure, finding out how long it needs to be done. Of course, everybody wants it done in and out as quick as possible, the clinician and the patient. But what is the best time of the day for the patient as well? Are they an early morning person? Does that work well for their system? Is it later in the afternoon? Do they need to have a nap? Where does that person with this dementia or Alzheimer's land? So it's important to understand that, so that way you can schedule the appointment at a time that works best for them. And if it's a time that works best for them, it will be so much easier and so much better for you and the rest of the clinical team. So just be thinking about that and when you're doing that. So to recap, we're discussing listener reviewed a requested item on doing treatment with patients with cognitive decline like dementia and Alzheimer's, especially local anesthesia administration. So we've talked about having an idea of where their cognitive level is, having a conversation with their care provider, making sure they have the capacity for informed consent, and what does that look like. And then the other thing we want to know is what works best for them. Any triggering words, actions, avoid that, and schedule them at a time in the schedule that works best for your patient. Other things to be remembering is that oftentimes there are other co-health issues that are going on with this. So we really need to look at the medications that the patient's taking, understand those medications, understand their side effects, especially if they have any kind of impacts with local anesthetics. There are not very many anesthetics out there that are very many medications that have a true contraindication with anesthetics, but there are some out there, and there's so many new medications coming out all the time that we really need to do our due diligence and just double check. And there's new research and information coming out. So we just need to do our due diligence and double check to make sure that the medication that patient is taking doesn't interact with anything that we're going to do with anesthetics. All right. So when is actually time to do the procedure of injections? One, we want to make sure we're doing as few as possible. So this is where coming through and doing more of your block techniques are going to be ideal, right? Because we want to do, especially if you're doing periotherapy, we don't want to have to go and do 4 or 5 injections, especially on the maxilla. We want to get them done as quick as possible and be in and out as quickly and safely as possible. So really be thinking about your procedure, do the fewest injections as possible. The other thing is really be thinking about the unpredictability of your patient. Now, we all have patients that are unpredictable, like we are people. And as soon as a syringe, right, comes up inside a patient's view or thought process, they become unpredictable, right? They could have 100% cognitive capacity, but for some reason at that moment in time, it all goes out the window and they forget, and their hands are flailing, and that's not great. With an individual with cognitive decline like dementia or Alzheimer's, that potential increases. So having somebody in the room with you when you are administering your anesthesia to maybe help hold a hand and provide encouraging comfort and words would be advisable in that scenario, if you can make that happen. If you cannot, then that's okay. Hopefully this individual has a caregiver that stayed with them while that's happening. Okay, so that can be a big comfort for the patient, and I think for us as clinicians as well, if we can have their regular person being there. So there is that. The other thing is because of the unpredictability of said patients, using a retraction device would probably be very, very helpful. So it could be as simple as grabbing your pliers that you have on hand with your syringe, because that's the safety thing, right? We're safety people. We don't want to stick ourselves. The only person that should be stuck with the sharp, pointy thing is the patient, not us, or our friends, our family, our coworkers, okay? So you could use the back end of your pliers to help pull the cheek back and retract so that you can get in and do your injection. You can use your mouth mirror. You can use a retraction device. There's a big slew of retraction devices. You can use a tongue blade. I've used tongue blades before for those as well. So that would be one of the things to be thinking about. When it comes to your injections, like I said, use as the fewest as possible So for the maxilla, you would do maybe a PSA, or maybe even if there only is 1 molar, an infiltration, and then either an IO or an AMSA if you can have the time and to be able to do the palatal approach, the AMSA, AMSA. Love it. It does a lot. So I would give that a try. When it comes to your mandibular blocks, this could be a challenge. You're going to have to play it by ear to see how your patient does. You may be able to go away with a traditional like gout gates, IA. Gout gates, once it's perfected, is much more reliable. So I will say that. But this might be an item where you want to do the closed mouth VA technique, because you don't have to keep coaching your patient to stay open. It is very innocuous, pretty benign for our patients. They don't really even realize that they have an injection happening. So pretty awesome. I think it is a underrated injection, mandibular block. I would love it to see more of us doing it. And I know that people who have taken my courses, when they learn the VA, they say, Tina, oh my gosh, I do this all the time. It's my favorite. Why do we learn anything else? So it does have a steep learning curve, but once you learn it, it's wonderful. So I would say that for a patient with some cognitive issues, that VA mandibular block, the Vazirani echinocces, would probably be a valuable injection in your tool belt to be able to provide anesthesia for them. So there's that information. All right. Again, retraction device, so that way you can stay safe. The unpredictability of your patient is real. Pay attention to your patient's medications. Make sure you have a conversation with the patient's caregiver before the anesthesia, and even after. Post anesthesia trauma, like lip biting, tongue biting, those things are going to be a bigger issue to have the individuals who are working with these patients, especially if they have severe cognitive decline, that they're going to need to have that help to remember, to pay attention, to see if the patient is chewing on their lip or their tongue. And that's just basic for anybody. We're working with our itty bitties, that could be an issue too. So having a conversation with our pediatric patient, whoever the caregiver is for our pediatric patients as well. Another thing to be thinking about is our dosaging. So in general, patients with cognitive decline are also elderly, may also have other health issues. Their kidney function, their liver function, their cardiac function may not be top notch. So you do need to be aware of that. Okay, so you do need to be aware of that. Okay, we've got a question. Oh, Kylie Good, the one who requested this. When signing consent form, should it be listed that the patient is with a caregiver, or should the patient sign anything knowing they are in cognitive decline? So that's a great question. So really, this comes under informed consent for anything. If the patient has not been deemed incapacitated to make their own medical decisions, achieve that where they can no longer make their own medical decisions, there's forms that go out with them. There should be. I've seen them, so I may be mistaken. So if anybody's listening to this and says, Tina, you're wrong, please correct me. But that has been my experience, is once a person has reached the capacity where they are no longer able to make medical decisions, there's a form, and those forms need to be presented at, thank you Alma, those forms need to be presented at every medical appointment, dental appointment, healthcare appointment. So if their decline is so much that they cannot make their own medical decisions, then it is the caregiver that signs. Whoever has the capacity to do that medical consent is who signs for it. Now, if you are not sure whether or not the patient has that ability, and you don't see like that that access has been taken away from them, right? It's like the driver's license. You don't get to have your driver's license anymore. But if they have not been presented with this information where they are not allowed to make medical decisions, or that you don't have that information, definitely have a conversation with the care provider. The patient still, that's the legal signature. It's the patient. So leading up to it, if you suspect that person is so mentally declined that they shouldn't have that, have a conversation with the people who brought the patient and find out if there is a medical waiver. I wish I could remember the name of it if you are listening and you remember the name of it, but it's basically kind of like power of attorney for healthcare. And there's a specific term for it. And I'm so sorry that I cannot remember what it is. But a lot of times our patients and their caregivers don't think about dentistry as healthcare. Yeah, it's sad, but they don't. And so they don't think about bringing that information to the dental office. Same thing like, oh, I didn't think about needing to bring the, novella of medications that they're taking. So a conversation for sure. And if the caregiver, whoever is with them, knows that there is a medical power of attorney, then we do need to have that. We do need to have that. But if there is not one in place or one that exists, then the patient legally still has that right. Now, in your chart notes, make sure you really lay out your PARQs. Maybe you don't just type PARQ, but really write it out. Like, what was the P, the A, the R, and the Q, that you reviewed all of that, and that you were able to get verbal and written authorization. And I will tell you, as someone who has been in mental, emotional, and physical distress going into the emergency room, me personally, where I am laying on a gurney, hyperventilating, like having no clue where I am at, they're like, because I could talk and I could move my hand, they're like, we need you to sign this form saying we can treat you. I had no idea what I was signing. But legally they needed it because I was still of what they thought was sound mind. Now, if it's emergency care, right? Emergency care, you just say, okay, like if the patient really cannot consent for non-emergency care unless they have a I wouldn't say it's not a DUI, because a DUI is drinking under the influence, but it is the DNR, do not resuscitate. So, and if a patient has a DNR, that needs to be on file with the dental office as well, especially if they're going to be having procedures done. So, yeah, sad. These are things we need to know. Whew. All right, friends, that was a lot. I hope it was helpful. If you have further questions, please let me know. If you have further thoughts, if you watch this recording back and have other information, please share with me. I'm happy to hear it, want to know it, because this is an ever-evolving issue. All right, so if you want to come back and revisit this, please go to Teacher Tina RDH on YouTube, because that's where it's going to be the easiest to find. And I do want to say that new videos are starting to be posted on YouTube. Yay! I'm putting up some of the videos that I put in my on-demand courses. Some will be on YouTube. So you can go in and look at those and kind of get an idea of what it's all like. So please share with all your friends and family. Okay? Right, you just share this stuff with your family. I do. I don't know. Okay, friends, that is it for this week. Thank you so much for being here and for being a part of the Teacher Tina RDH family and supporting all of this viewing and sharing it with all of the people in your life who are also passionate about dentistry. Couple of things to be aware of is I will be in Georgia doing anesthesia certification for hygienists in Georgia in the McDonough area at the end of June. Then I get to take a vacation. And then I will be in New Orleans at the ADHA conference doing a 1-hour interactive mandibular injection techniques workshop. Boo boo. So that's exciting. Thank you, Septodont, for sponsoring, and Septodont and Kilgore working together and sponsoring that session. So I'm super excited about that. And then after ADHA, it'll be off to RDH under one roof, also doing a couple hours of anesthesia CE. And then you'll see me with a couple of other organizations doing some webinars coming up this summer as well. So just if you're curious, That's what's going on. And with that being said, I'm going to go make some homemade hummus and grill up some halibut. What a combo, right? All right, friends, thank you very much, and I will see you next week. Cheers. Bye.